Hello, my name is Paige Kerrigan. I'm a second year pharmacy student at UNC Chapel Hill. Today, I will be talking to you about news you can use for the late weeks of 2023 carrying over into 2024. With that being said, let's get right into it. Here is an overview of my presentation today. We will start with some guideline updates from the ADA, and then I will spend some time going over updates in atrial fibrillation management. And then I will go over some drug label changes and drug safety updates on Prolia and GLP-1 agonists. All right, and we're going to start with the ADA's Standards of Care in Diabetes for 2024. The ADA added the RSV vaccine to their list of suggested vaccines for patients with diabetes because adults greater than 60 years old with diabetes appear to be a risk group for infection with complications. That being said, it would be best practice to encourage our patients 60 years and up with diabetes to get their RSV vaccine and remind them of all other vaccines that may be due. The ADA also updated their section on non-alcoholic fatty liver disease. So they suggest that adults with type 2 diabetes, particularly those with obesity and cardiometabolic risk factors or established cardiovascular disease, should be screened risk stratified for clinically significant fibrosis using a fibrosis 4 index, even if their LFTs are normal. So this is because, according to the ADA, diabetes is a major risk factor for developing NASH, disease progression, and worse liver outcomes. Recent studies in adults in the US estimated that NAFLD is prevalent in actually greater than 70% of people with type 2 diabetes. Also, more than half of patients with diabetes and NAFLD are affected by steatohepatitis, which appears to be a driver for the development of fibrosis. The FIB-4 score takes into account AST, ALT, PLT, and age. It's a useful tool in assessing a patient's risk of fibrosis, and the scoring is as seen here. Those at low risk will have a FIB score of less than 1.45, intermediate risk 1.45 to 3.25, high risk greater than 3.25. And I will also mention that clinically significant fibrosis is defined as moderate fibrosis to cirrhosis. Bempedoic acid was also added as treatment for primary prevention of ASCVD and statin intolerant. It was also added as secondary treatment for those who are statin intolerant. Bempedoic acid is a suggested treatment along with PCSK9 inhibitors or PCSK9 inhibitors with inclisiran. As a reminder, bempedoic acid inhibits cholesterol synthesis in the liver. It reduces LDL by about 20%, while PCSK9 inhibitors lower LDLs by about 45 to 64%. Also, to address further cardiovascular concern in patients with diabetes, we should screen for peripheral artery disease. This screening should be completed in two subgroups of our diabetes patients. One are those who have had a diagnosis of diabetes for greater than or equal to 10 years, and those who are greater or equal to 50 years old with any type of microvascular disease, foot complications, and organ damage, things like end-stage kidney disease, for example. Moving on to updates in AFib. A joint committee updated clinical guidelines for the management of AF based on systemic review of evidence published through November of 2022. Apart from a limited update to the AF guideline in 2019, the last comprehensive update was published in 2014, and the management of AFib has changed considerably since it's released. So today I'm going to talk to you about how it has changed. Well, it has changed even from the point of diagnosis. So previous guidelines focused on the duration of AFib, and new classification shows that the stages of AFib are actually on a continuum. There are stages 1 through 4, and then stage 3 is further divided into 4 subgroups, as you see here on this chart. Stage 1 is the management of risk factors, modifiable risk factors being obesity, hypertension, diabetes, alcohol use, etc. Or there's non-modifiable risk factors including genetics, sex, and age. Stage 2 is no evidence of AFib yet, but at a higher risk of things like atrial enlargement on echo or atrial flutter. Stage 3 includes paroxysmal AFib, persistent AFib, long-standing persistent AFib, and successful AFib ablation. Paroxysmal AFib is for less than 7 days. Persistent is greater than 7 days but less than 12 months. Long-standing to persistent AFib is greater than 12 months, and then successful ablation is 3D. Recommendations for AFib are made on a yearly thrombolytic event risk using a validated clinical risk score such as CHA2DS2-VASc. However, patients with an intermediate risk score who remain uncertain about the benefit of anticoagulation can benefit from consideration of other risk variables to help inform the decision, or the use of other clinical risk scores to improve prediction and facilitate shared decision making. Atria and Garfield are newer clinical assessment tools to assess the patient's stroke risk. Atria includes a few more things than CHA2DS2-VASc, like proteinuria and renal dysfunction. One of the reasons they don't want you using one score in isolation is because certain things promote both bleeding and embolism, like age, hypertension, or renal dysfunction. With the emergence of new and consistent evidence, the guideline emphasizes the importance of early and continued management. Management should focus on maintaining sinus rhythm and minimizing atrial fibrillation burden. This is emphasizing that the newer guidelines focuses on early rhythm control, especially those with intermittent and paroxysmal AFib. Here on this slide, there is a chart, and these are patient and clinical considerations for deciding between rhythm and rate control strategies in a patient with high burden of atrial fibrillation. This is broken down based on patient factors and findings on physical exam. One factor is how long the patient has had AFib. So the longer you've had AFib, the more remodeling of the left atria. Also, symptoms burden take into account. So fewer symptoms, you may favor rate control. For physical exam, if you have difficult to control heart rate, smaller left atria, or more left ventricular dysfunction, and the more aortic valve regurgitation, then rhythm control would be preferred. This chart is showing the schematic of AFib treatment. The purpose of this slide is highlighted in the red. The red box highlights the changes in the guidelines. Catheter ablation of atrial fibrillation receives a Class 1 indication as first-line therapy in selected patients. Recent randomized studies have demonstrated the superiority of catheter ablation over drug therapy for rhythm control in appropriately selected patients. Here are the updates from the AFib guidelines. They read, symptomatic AFib plus antiarrhythmic drugs are ineffective, contraindicated, not tolerated, or not preferred. Then catheter ablation would improve symptoms. In select patients, for example, younger with few comorbidities, with symptomatic paroxysmal AFib, catheter ablation is useful as first-line therapy for symptom improvement and reduced progression of persistent AFib. In patients with symptomatic or clinically significant atrial flutter, catheter ablation is useful for improving symptoms. In patients other than younger with few comorbidities with symptomatic paroxysmal persistent AFib who are being managed with a rhythm control strategy, catheter ablation as first-line therapy can improve symptoms. Here's the current treatment algorithm for the maintenance of sinus rhythm. What I will point out is in red, and that is that flecainide is associated with an increased mortality when given to those with prior MI, and dronedarone, amiodarone's cousin, is contraindicated in heart failure patients. With that, we have covered the guideline update portion of this presentation. We will now be covering drug safety updates from the FDA. Starting off with Prolia, or denosumab, a subcutaneous injection for osteoporosis. The FDA has added a black box warning on this medication for increased risk of hypocalcemia in patients with advanced chronic kidney disease, especially those on dialysis. Severe hypocalcemia seems to be more common in patients with CKD who also have bone mineral disorder. It is important that prescribers assess patients' kidney function before initiation of this medication and monitor appropriately. Next is a report on glucagon-like peptide 1 receptor agonists. The FDA is investigating their psychiatric side effects after reports of suicidal thoughts and actions from patients being treated with these types of medications. Previous clinical trials and outcome studies have not shown association between the use of GLP-1 agonists and the occurrence of suicidal thoughts or actions. As of right now, patients should continue to take their GLP-1 medications under the surveillance of their doctor, and prescribers should monitor for and advise patients using GLP-1 agonists to report new or worsening depression, suicidal thoughts, or any unusual changes in mood or behavior. So that is all my information on the news you can use for early 2024. Just to go over what we talked about today, we went through the ADA guideline updates, and we also went through the atrial fibrillation management changes. And then we ended with drug label changes for Prolia or denosumab and a drug safety update on GLP-1s. Here are my references. If you have any questions, feel free to contact us at the Moses Cone Family Medicine Health Center. I'd like to thank Rachel Shelley, our PGY2 resident, for helping me on this presentation, as well as Dr. Koval. Have a great rest of your day.